Hey everyone, this is the Nips and Sips podcast featuring me. I'm Dr. Jeremy Boyd and partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about the junctions of the spine. So we're talking about OA, CTJ, and thoracolumbar junction. I guess anything else that Brandon comes up with too. But before I get too much into that, let me pass off to Brandon. How's it going?
Going well, Jared. Thanks for the pass off. Excited to talk about the junctional manipulations. I know when we were first learning them, it's a challenge, but it's always fun when you get them and you become successful, and then you start applying them to your practice patterns and treatment, and you'll be surprised on the results you get when you apply it to the correct patient or person. Before we get further into that, let's talk about our drinks. This is a morning edition because it's 8 in the morning. So I have a Scotch whiskey in my coffee. So I'm making an Irish coffee, but I want to try this by itself. I haven't tried this new bottle. I just got it for my birthday. It's, if I'm pronouncing this right, Lafroig, something like that. It's from I'll say Isla, something like that. Some island off of Scotland. So I apologize for butchering it. But anyway, that's what I'm having. So one of these days I have to have it just on the rocks and let you guys know how it is. But what do you have, Jer?
I got this is from Flying Fish, tropical wheat or Tradewinds tropical wheat. So I just went to their brewery, or at least the outside of it, because they're not allowing people in. And they it was a cool brewery. Flying Fish is one of the bigger, older breweries, been around for a while. And so it was nice to be outside. They did a good job social distancing. And this is more of a tropical drink. I liked it, actually. More of a lighter beer. But you can tell you still like the mango, and I think it's a guava into it, passion fruit. So I give it a 7.6 on my scale.
Is that sour or no?
Mm-mm.
All right. I know those mangoes.
I think this is just a wheat beer. So yeah, the sours. So it's starting to slip out of that season there.
Got the name. It's Isla.
Isla.
Yeah, it's an island off of Scotland apparently. So.
Oh, Isla. Oh, I'm drinking out of Barn Door Brewery. I don't really remember where this one was, but it's one of my few mason jar style ones. I think it was in California. It may not have been really open yet, but anywho. So we want to talk about this topic today because I feel like it's something that can be commonly missed. Looking at students, and then I pick up, and I think Brandon as well, picked up a lot of clients from other PTs or other practitioners where the job wasn't quite done yet. And a lot of times, I believe a lot of those issues can be due to, I guess, lack of treatment towards these junction areas. So the main ones are your, as we discussed, I think most ones I probably do is for CT junction, then probably TL junction or thoracolumbar junction, and the OA. Brandon, what about you? What's your thoughts on these areas?
Same. I do those three. I guess initially got turned on to the first junctional was residency with that CT junction, the prone CT junction minute.
Mm-hmm.
I find that was my favorite. That also I found that better than the seated CT distraction one that you do.
That's my favorite.
What's up?
And that's my favorite one.
Yeah, I don't know, maybe it's just the way I'm doing it. I just find that the seated one's a little bit more general. You get a lot more thoracic stuff. I feel like personally I can target more specifically, or as specifically as we can, knowing that, some of the stuff is non-specific. That CT junction, and I think with the junctional manipulations, we get to really target the best of both worlds. We get that lower cervical region, and we get that upper thoracic region, and maybe the associated ribs as well as the costovertebral junction is attached to the thoracic vertebra. So you're kind of getting a lot for your money right there. Big bang for your buck.
Mm-hmm.
I guess my second, in the way I learned it and kind of those aha moments in my career was the CO or C0, C1 junction for especially migraines, not so much cervicogenic headaches, but more migraines. That is a tough manipulation to get. You need quick hands. You need to really angle it properly and make sure you're trying to be as specific as possible. And then last for me, I guess, was that TL junction, which I learned probably a couple of years ago and really was able to, I guess, like you were talking about, patients get better, but they kind of have that lingering symptoms, and performing these was able to kind of drive home and get them that extra, 10-15% that they were kind of lacking. But that was my evolution. What was yours?
Yeah, I guess kind of similar. It started obviously in residency for us, where we learned both those, the prone technique and the seated. I guess they call it the full Nelson technique. I don't know why that one kind of worked better for me, probably because of a bony chest. It just, I don't know, it was always the easy one for me. I agree, it doesn't get as specific as like where you're putting your hands on the prone techniques. Just, I don't know, you can get a lot better with that. But I do kind of say with like students and those sort of things, it's like, this is one who kind of just really kind of blow. I don't say the clients, just the students, blow up the area. That one, I feel like, some, especially for those stiffer individuals, that one can do a good job. And, it's probably because at the time I was treating a little bit more of a geriatric population and getting people on their face and eye when they're a little bit older. Couldn't get too many of them. But now, again, it's just more my lack of experience and stuff. Then, yeah, I believe you taught me the COC1 technique. Yeah, I think that's how it kind of went. And I remember treating a lot of cervicogenic headaches and those sort of things. And I was just doing either probably some general, maybe cervical manipulations, and it was getting better than when I used to have these clients. And I think I just had like them do chin tucks and just like PA mobs. And they would kind of be good, maybe some slight decrease in frequency or duration, but couldn't really fix them. And that's when I started really applying those techniques and starting to get really good outcomes. And then, yeah, in a couple of years, been doing that kind of rotational thoracolumbar technique, the supine one, and a couple others. And that's been really good, especially for me. A lot of CrossFitters and Olympic athletes or Olympic lifting athletes, whatever you want to call it, a hinge point, or they're just where they kind of arch their back into extension to keep themselves up for like snatches, or those sort of things. That area is always kind of jammed up and causes these kind of referral pains into the hip and the groin, and we start chasing that. But I stopped. I think for me, I think I might have mentioned it in previous episodes, I used to get a lot of those classic impingement-y type of hips with these CrossFit and Olympic athletes. And, just second nature was just like doing the belt mobs. And then I was just like, let's look for a better solution. I remember us discussing these things and starting to hit in the TLJ, and that was like money. All of them started to feel better. They started referring a lot of people because it was something that I wasn't the only one treating these individuals. They were getting either massage, chiropractic. So I think one or two people were going to another PT, like currently, to a different state. So that was kind of my evolution. And I've kind of learned and seen that these junction areas take a little, for all of them, I'd say all the techniques, a little more finesse than your standard techniques. Maybe that's why it's missed a little bit. I do remember how frustrating they were. I don't know if that was at Old Pursue, your first spot. of you teaching me that CLC1 and how I just
Yeah,
wasn't fucking getting it.
I think that's me teaching. What was that? It was Pursue 2 really, because I had 2 offices at that time. I was in a gym, right?
Yeah.
And it was just when we started the continuing education company, right? And it was like, all
Yes,
right,
we're preparing
let's
for
go
it.
over some techniques, make sure we both are comfortable, yada yada. And that COC1 is a tough.
Mm-hmm.
Yeah, so that was there. I want to before we talk about that, let's talk about that TL junction. Talk to the audience, and I'll chime in. What kind of subjective report, or maybe even some objective things you find that lead you to assess that TL junction in that population? Because, especially nowadays, a lot of PTs, or even chiros, I don't know if chiros are listening to us, but a lot of PTs are opening up in the gym setting. Awesome. Great. But are you missing something? Can you be more effective? How can you help these patients more? And what Jeremy and I have learned over time, it's really the mechanism of injury, and kind of listen to what that patient's telling you. If you can identify the areas that you can create a hypothesis of what to assess and check and go to those areas and then confirm it, or not confirm it, from there, rule in and rule out, you'll be much more successful. So for you, one therapist in the gym, I mean, hopefully you're working out as well, so you kind of understand this a little better. For you therapists who aren't in the gym, we encourage you to understand movements of basically all the types of people you will work with, from lifters to athletes to construction workers to moms to doctors, whatever the case, a desk, someone who works at a desk, or a businessman. Like, trying to understand the movements and mechanisms of all these different types, because that's going to help you greatly. But Jared, what are some of the things that some of these patients tell you that cue you in? Hey, let me check the TL junction. Or like you said, you used to treat the hips. What made you want to check the lumbar spine? What made you want to check further up the lumbar spine to that TL junction area?
Yeah. And just build off the last thing you say is also builds rapport with your clients, knowing what they're going through and that sort of thing. So, going back to our previous episode with Kyle, patient education, that's critical. But in regards to TL junction, so something that I, again, missed for quite some time, unfortunately, but, always learning and growing. A lot of these people, I mean, I think even because in the CrossFit competitions, I'll get people to jam that up. I think there's a video of me way back on Instagram doing guys. Dude, his name is Big Al. This guy's massive. Tree trunks for legs and arms. And I'm on a portable table trying to do the rotational TLJ manipulation. And that was mine. I think he ended up coming in second place, first place. I can't remember. So I always try and take a little credit if they do place. But
of course.
So something that they'll report is a lot of them it's hip pain. I'd say probably more often than not, they got that hip pain. Even they'll say the classic pinching at the end of the squat. They'll even kind of C-cup it, like here, like this is where it's at, or something like that. And it's I guess PT human nature, but it's got to be impingement or labral issues or something intra-articular. So it's
OS muscles.
Yeah, so it's like boom, you wouldn't even have to think more than that. It's like, all right, I already can be the man for this person. And they'll report something which I think we don't take enough credit for. Is a lot of these patients will say, oh, I ask them, either they'll say in their subjective interview, or I'll ask, you have any issues anywhere else? Or I think Ernie taught me this, and he's a fellow, touch each joint. Sometimes I do that. I'm like, any problems here, here, here. And or if you get the diagram, go through it. But one way or the other, the patient reports just like a stiffness of the back, or always have back issues or those sort of things. And I think a lot of times, or maybe I did, but watching students and those sort of things, or residents, something like basic like that, I have like a stiffness in my back sometimes. Oh, okay. And then you just let me keep focusing on the hip. And I think that's a big telltale sign that there's something potentially going on also in the back for those individuals. And once I started connecting that dot of that anterior kind of intra-articular hip pain with, the stiffness of the back or those sort of things, that means, I should probably at least check that area more thoroughly. I do like active range of motion with overpressure, but oh yeah, it's tight, it's stiff, and those sort of things. And you start diving into some more questions. Do you feel like they're connected or correlated? Sometimes they do, sometimes they don't. But besides that, having pain in the back, even just now at this point, if you're reporting pain in the back, I'm obviously going to assess above and below thoracic spine, those sort of things. But as we said here, a lot of times pain is a liar. Where it is not, the origin. So they'll be like, oh, here, and especially if they're coming from, physicians or something like that. Not all physicians, because I'm starting to see better physicians. They're like, yeah, those things are normal, but they're like, I get this L4, L5. I'm like, I got herniation. I'm like, let me guess, L4, L5. They're like, oh yeah, how'd you know? I'm like, it's like statistically, you're gonna probably have one. But they even kind of know where L4, L5. I don't know if they've done enough research where they're like, oh, it's right here. And then you start playing around with their TLJ, and it's like, wow, it's painful there, and I'm feeling it at L4, L5. So that's kind of, I'm assessing pretty much for all my low back pain patients, and then any of those hip pain. And then going into the objective side of things, yeah, I can say those individuals, they'll have a positive fader. I don't know how you guys want to talk, FADDIR. So the flexion, adduction, internal rotation test just can jam up that hip. A lot of people say it's for impingement. We know those tests kind of suck. But they can have a limited log roll, they can have limited internal rotation, they can have pain in their hip and groin with this. And that's, used to be good enough for me to be like, all right, I'll just take my belt right there, won't even finish up the rest of my exam, start mobilizing it. Like, oh, yeah, it's a little bit better. And I'm like, okay, great, that's it. I used to take a little bit better for good enough. And now I'm like, no, that's a little bit better is not good enough. I want them a lot better.
Not better, actually.
Yeah. Yeah.
It's not better if they say it a little bit better.
Oh yeah, and half the time
they're trying to be nice.
Clients are trying to be nice. Yeah, they're like, oh, he's trying. He's working hard. Great. Yeah. Good boy. But really actually working on the client, especially these individuals, if they had true hip impingement, they wouldn't really have that real limitation in range of motion. You'll have people eventually get them into that fader position. It's one of those things that's, going to be uncomfortable to a degree. The body's not really meant to move like that. But if you're winding them all the way out and their foot's like 10 feet off from the table, and they're like, yeah, that hurts. That's it. I'm like, yeah, is it really a intra-articular hip issue if they're having more than like 30, 40 degrees of internal rotation? Probably not. So kind of actually diving in, going a little bit more. I put a lot of weight into essentially palpation or, assessing the mobility of TLJ. I'll do the CPA or bilateral UPA. And if you put enough weight into it, you got to think they have a lot of weight coming down on them, at least in my population of Olympic and, CrossFit athletes. You have to put a little load through that. And then all of a sudden they're feeling it in their hip, not just, oh, I feel it in my back because, I'm a 190-pound dude pushing down on me. No, it's like, oh, I feel that reproduced in my hip.
Yeah.
Then, wait, this is not a hip issue. But what about you, Brandon? I know I got some of these techniques and examination from you. So what about you?
Yeah, I mean, you said a lot of what I would say, but just to kind of fine tune, because I know you
You
and I are
think?
very similar in thought, which is could be good or bad. Uh, yeah, unilateral PAs I find to be more effective or more provocative for patients. You're loading up that one side. Um, Patients talking about deep achiness by like their greater trochanter, usually bilaterally, especially in that weightlifting population, squatting or overhead squats, regular squats, cleaning and jerking, snatches, stuff like that. That population. Football players, linemen, I've seen, especially because they're in that kind of 3-point stance and then they're driving up into lumbar extension against the guy. I'll see it in those. So a lot of patients will report like they hit their hips or they try and roll it out or they use those massage guns to try and get
Mm-hmm.
relief, and like they get no relief at all. And it's because they're treating the area, the site of where the pain is and at the origin, like you were talking about. Also, that TL junction can refer down to that SIJ region or anterior hip, like you were saying. So really, those three, I find that that P to A mobilizations, and they'll clear up quick. We're talking like probably what 2 to 4 sessions, Jared, on those
Uh,
lifting people.
yeah, it's usually
If
money,
that.
like 1 to 2, and it's usually something they've been dealing with forever.
Mhm.
Um, and
Or what I've
again,
noticed when you get to a certain weight, like you could squat, like 50%, no problem. But when they say they get to 80%, 90% max levels, that's when it bothers them. That's probably where they're leveraging their back, going into hyperlordosis or arching, and that becomes the area that takes the brunt of it
yeah,
on those patients. Yeah, I like to do the prone thoracic or prone TL junction manipulation. I guess we'll pull up some videos in a little bit just
yeah,
to let everyone see what we're doing. Let's move on to the CT junction. That's a big one. That's one of your favorites.
yeah.
What are you looking for there? What are some signs and symptoms? What's the patient reporting? What kind of cues you in?
Um, yeah, definitely a favorite. Definitely a lot of different styles of techniques that you can do with this, which is good. They always got value what the patient wants or what position they want to be put in or comfort level. So hopefully we can get some videos up on that. But yeah, a lot of what I'm seeing, again, same sort of thing. Someone been dealing with it for a while, a lot of the times, or even not actually. Also pretty common in weightlifters, more from this time like back squatting or dropping the barbell down as they like transition from over at like a front squat or press and jerk, and then they in a WOD switch to a back squat or whatever it may be, and you can just see it becoming more and more kind of hypertrophic, a little stiffer. But a lot of what I see is, that classic sort of, oh, I got trigger points in the middle of my scapular region and got always a tight upper trap. I start to, those are those kind of telltale signs. They can even have, pain down into the arm, and the shoulder. Yeah, those are the big ones. Anytime I see like people are like this and they get the guns and the lacrosse ball up into there, and with no luck, but they'll do that for months and months. But those are kind of the big things that I see. From a movement perspective, they don't have really um, like much like thoracic extension, and I feel like cervical extension is usually kind of something I feel start to um, be, if it's like a true like just CT junction, they're like can't get back there. They'll like capital extension and they'll be like this, and they don't actually truly get all the way back because that seems like that jams it up more. Something I learned in my fellow is like kind of start to ask when in the range of motion it starts to bother the client. If it's like I'm good, and then towards the end, you're starting to think like they're stacked on bricks, and that motion starts at C1 and starts to work itself down. You start to see that towards the end of the range of motion becomes painful. That's when I start to see that it's more CT junction. And that's when I want to say I won't blow it up, but but what about you, Brandon?
Lately, I know this is anecdotal. I've been diving into these frozen shoulder type, at least diagnoses that a physician will give. Oh, shoulder pain, you're limited motion, you're 50 years old, you're a woman, it's frozen shoulder. I've had 3 cases literally in the past, couple months here, and they've been responding well to CT junctional area. So probably I would say more C6 down to T1. And I'll be honest, haven't even manipulated the CT area because they're a little stiffer. I'll go to P to A's. So, we obviously we like manips and talk about manipulations, but P to A's, unilateral P to A's, just as effective. Downwarders humps. You were talking about those people, people who are stiff, and you could just tell that that's a hinge point, or that's an area that, I don't know, for lack of a better term, is not stacked properly. I'm going to try and loosen that area up, quote unquote, loosen. I know that's probably not what's going on, but for in terms of purposes here, loosen that area up, target that. I'll let them prone, because those older patients, and you touched upon it earlier, especially older men, but you could throw older women there who are just stiffer and can't tolerate that combined motion of kind of rotation, side bend, extension. Just get them in prone and mobilize them. So I find that you said it with the referred pain patterns, that somatic joint referral. Usually it's pain into the shoulder blades, or feel like they have trigger points, pain that's always kind of hopping around. Overhead athletes, baseball players, pitchers,
lack of rotation,
especially. Possibly gymnasts. You talked about Olympic lifters or CrossFitters when they're overhead pressing and jerking. They have a lot of weight, a lot of stress there. Anytime somebody comes in with shoulder pain, especially impingement shoulder pain, just like we talked about with the hip, that impingement tends to be coming from somewhere else, and that tends to be that lower cervical, upper thoracic, maybe even the associated costovertebral joints. So I'll try and clear all that stuff up and assess it, do some spring testing, treat the TL junction. So, the first rib obviously goes there between C7 and T1 there. So they're down to C3 or T3, even CV3, I should say. Costovertebral joint 3 and thoracic spine 3 is usually where I'll try and work out. And just to define these junctional zones for everybody, TL junction is defined, at least in text, T10 to L2. I'm sure there's some wiggle room with that. I mean, some people might, you might reproduce their symptoms while you're at T9. You don't have to be very dogmatic or so dogmatic. Just understand where you're at and what you're trying to do. CT junction, we're talking about C6 down to T2, and then obviously our C0, C1 is self-explanatory to that. But maybe you could throw in C2 there as well. But I think what was I talking about? The shoulder pain, impingement. I'm assessing the neck. We've talked about this before on the show, but clearing that TL junction seems to kind of drive home the point. And then I guess we'll just finish up with the C0, C1. How are you treating that, Jared? Well, I guess what are some signs and symptoms that are cueing you in or cluing you in to assessing and treating those areas?
Yeah. And just go back to CT junction. I would say, looking at both my resident, so as a different person, and myself, just looking at our caseloads, who's doing better, and all those sort of things. For any elbow sort of thing, if you're not addressing CT junction, you're definitely missing out, and your clients are missing out, because I would say it's more often than not the most effective thing. If you've had tennis elbow or golfer's elbow for years and you're just looking for some sort of true relief, you're not providing that CT junction, you're definitely missing the ball there. But that's probably, I think we already talked about in another episode. But
It's good to
going up
recap.
to, yeah, so passionate about that. God, people. But going back to that CLC1, and something I guess probably more newly implemented by me. I've been doing like the OA flexion techniques and stuff like that since residency, but just getting into a little bit more nitty gritty. You know, pretty much anyone who has, comes in, pretty much reports any sort of headache. I don't even really care. Whether it's like tension or cervicogenic or cluster or migraines or anything like that. And they're coming in for neck pain, but I always ask them, do you have any headaches or anything like that? I start to think up in those areas. Obviously, I get a little more. Was that? You broke
Sorry,
up a
I was
little.
throwing in concussion and whiplash patients too.
Mm-hmm.
Treating those areas is often
Yeah.
underserved in those populations, and then you wonder why they have concussion symptoms for 6-8 months.
6-8 months or years. I mean, I've had someone.
5 years study.
There's a girl. She was starting to close to missing her second season in high school because no one treated the neck.
Yeah.
And that was something I did, just worked on up. But I'm sure we talked about that case. And again, by the time they get to us, I don't know about you, but I don't get too many acute concussions or whiplashes. It usually takes some time and probably just need some cervical stuff in the beginning. But anywho, yeah, so any of those type of headaches, I'm definitely looking up into the upper cervical spine. I mean, looking at the upper cervical spine is now part of any neck or kind of T-spine issue. Pec stuff, clavicle, upper trap, especially the upper trap area. That I'm definitely looking at those upper segments, just because it works. Obviously, with like cervicogenic headaches, that's probably the one I'll get most excited for. I'm like, this will be the easiest one. But a lot of these, especially referral pain down into the neck, this is the classic one. People go up, and I used to be like, "Oh, it's all levator." It's like, "Oh, it's up back to the back of my ear and kind of goes down." And
we do some soft
levator. I was a terror. I did scraping. I did myofascial. I said fuck exercises at one. I mean, fuck manual therapy at one point, because that was a classic of me just trying to soften up that levator, and they would be stacked with those trigger points and ischemic compression, that bitch. And they'd be like, "Oh yeah, it's better." And then it's just they come back in as if the 20 minutes of work that I did was nothing.
Yep.
So especially those trigger points. I mean, I know there's stuff with dry needling. I just taken dry needling and addressing some trigger points and stuff like that. But for a while, I haven't addressed any real trigger points in my care in years. I used to like body scan people for them to a degree, and you start chasing those buggers, just not getting really get good results because you're treating a symptom. But other things I digress there. To kind of flip it from the CT junction to where we are at COC1 is, especially pain in the earlier ranges of motion. We know most of our rotation comes up in those upper cervical segments. So it's like those people are and they can't move at all. That's a big thing that I'm looking for more primarily just addressing that area. So versus like, oh, I'm good. And that's where it is. I think start to think a little bit lower. And that's a biomechanical approach. I can clearly just do whatever I want to the neck and it'll probably get better. But as I mentioned before on the podcast, I can treat biomechanically and be specific because I feel like in my experience, and me and Brandon have gone through rounds of getting our, I guess, outcomes critically evaluated we're constantly look to become more efficient. It's like you look at your caseload and how many times you've seen a person, and it's too much. We get our balls chewed out. Trying to be more efficient. And me personally, treating specifically, especially with my techniques and my self mobilizations, exercises. The quicker the person feels better. Now, most necks and stuff like that, I can probably get them done in a week to 2 weeks. Unless it's something extremely chronic, but looking at these sort of things, that's how it's become more efficient. But what about you, Brandon? I talked for a long time. Any more beer?
Yeah, I would say, well, a lot of what you said, headaches is a big one. Migraines, really, if we're really specific to C0, C1, that area seems to be, bogged down. I think we talked about this on our migraine or headache podcast episode. Talking about dry needling, we should do a dry needling one now that you took your course, though we can't do it. Dry needling the muscles around it, and even let's put the joint capsules around those areas to loosen everything up. I mean, I noticed that the biggest change, where if I could dry needle and then manipulate, I mean, the outcomes are faster. People are better, quicker, more profound. You talked about CT junction and the elbow and things like that, and tracing trigger points. Yes, trigger points are symptoms. I rarely ever, especially in the spine, treat trigger points. I'm treating the multify of that level, and maybe am I getting somatic changes as well? Probably and possibly, but needle that CT junction area. Bless you. That CT junction area on someone complaining with tennis elbow, especially those chronic ones, and they'll clear up just from there. That becomes a pain pressure threshold thing. Central sensitization, clearing up some of the referred pain there. C0, C1, we'll show a couple videos on that. I don't know if you have any queued up, Jared. I have a couple videos. I guess we'll transition to there. I think you did a great job explaining the symptoms. I'm with you. I think that neck is easy once you start integrating some of this stuff and become good at it. And again, it doesn't have to be manipulations. You could just do P to A's, probably grid 4+. These people, you'll notice outcomes and progressions that you didn't have before, especially when you take a step back off that soft tissue junk that, maybe you need to do soft tissue for 3 minutes because the person either wants it or you feel it might help calm down some areas, fine, but no need to do 20 minutes worth. Especially when you're seeing, a bunch of people an hour. Save your time, be more effective and efficient with your treatment.
Absolutely.
Anything else there? Because if not, I'll queue up.
No, let's start launching. I agree. I always tell all my students that, you don't ever need to manipulate anything. Mobilization will be just as effective. But, the main thing is that it has a better short-term effect. I'll say, maybe I have a personal bias, but I know, just seems to make a person feel better for a little bit quicker. But if you're not comfortable with it, mob it. You're not comfortable with mobs, and you probably need some education. But let's fire them up. I think I gave you sharing abilities. I got some.
Try it right now. I'm getting blocked, but I also got a new computer and just re-downloaded Zoom. So maybe it's a settings thing. But let me see. Hold on. I have to go to my system preferences. Give me a second here.
See if I. Ooh, all
right. So
you got it?
I did. I don't think it's going to be active because we're in the middle of a thing right now. Oh, here we go. It worked. All right.
Here we go.
Let's see that. So this is a modified version of the prone TL junction manipulation here.
To perform a modified prone TL junction manipulation, have the patient lay prone, propped up on their elbows with the shins off the table, with your stabilizing hand over the sacrum while tractioning inferiorly. Take the manipulating hand and place it over the L2, L3 region, traction superiorly so that the tension is over the TL junction region. Apply a traction thrusting force superiorly with the hand that's over the TL junction, while adding a counter thrusting force applied inferiorly simultaneously with the hand that's on the sacrum.
Oh.
Awesome. All right. So I'll turn off the volume so you don't have to hear me talk through it. But that's just these videos are pulled from our database that we have here. It's step-by-step instructions. So if you guys want to learn how to do these manipulations and probably about almost 100 others, this can be found on my website page and downloaded. And you guys have unlimited access to it.
What a deal. But
let's see, upper thoracic.
and if you guys think like, I know, Brad, you might have been the king at this, but if you don't think you can learn stuff, especially manual techniques from videos, you certainly can. That one, that seated CT junction manipulation that I want to come across.
Yep.
That was me watching a video very thoroughly from someone else. And yeah, you can learn these sort of things. Obviously, you want to be probably not practicing your first couple on a live client, but you can certainly, take your roommate, take your spouse, take a fellow PT, and learn these techniques from videos. And
so this is a supine OA distraction technique, a little easier than that rotary one I'm about to show. This one probably more non-specific, as you're probably going to get a lot more in the cervical and even all the way down to the CT junction there, but much easier to learn than what I'm about to show you. Jay, do you have your, I might have a video of you here. Oh, we have the CT junction one. I totally forgot about this one.
This one's a good, yeah. This is a great mob.
Yeah.
I'll be honest, I don't manip this one as much, but a great mob for it because it's tough to, in all the positions, to really mobilize the CT junction. So I think this is a great one, personally.
And I think I mobilize in this whole video and then just show the thrusting component at the end.
At the end. Look at that. The guy's probably falling asleep right now. This is like butter to him. This is the part I love. I think he's starting to go into some rotations. So this is great for overhead athletes. A lot of our rotation comes from our T-spine, and we severely lack that. And, Brandon's able to, get into some rotation at that one point, and that was the thrust right there. So really good technique.
We'll go to the prone one here.
To perform this prone CT junction variation, have the patient lay prone.
There he is. So, is there at least probably, there's prone, just two prone versions. There's a supine, 2 seated, 3 seated. So at least 6-7 techniques to get that CT junction.
We have a lot of variations here. Go, Jared. This is actually you demonstrating here. We'll finish this one for the audience.
Scared. That voice. You poor people having to hear this. Especially. Is it working? I'm still just seeing you, my man. Sharing it?
I thought I was. Maybe not. I'm just watching it by myself over here.
I mean, it's a work of art if I'm in it, so watch away. But don't deprive the people of this.
In the admin mode right there. Let's go back to the beginning there. Is it up?
Oh yeah, now we're on full screen, baby.
Yeah.
Look at that. Woo. All right. Shout out to that's my student Jamie, who decided to take our course.
Yeah, this was our early March course, right? Right before
early
COVID.
March course. Yep. So I'm probably making fun of her, as I typically do. There's Stud Justin behind me.
What do we have?
That's good.
People at this course?
Mm-hmm. So just making kind of cues a lot of time with when I see students, because it's great that we're starting to see some more manipulations in some schools, but a lot of the students kind of add that forced flexion into the CT junction manipulation of the neck, and that's what I'm saying not to do, because most often people have pain, especially the terminal end range of their cervical range of motion. So you cranking them into cervical flexion is not the nicest thing to do. So just be aware of that. Everyone is like, you want them to be relaxed. This is kind of done right, not any aggressive technique at all, but just look at imaging wise and those sort of things. It can be viewed kind of aggressive because you're essentially getting someone a full Nelson. So you want to make sure they're relaxed. And those certain situations, if you're feeling their arms are super tight on you, or they're like this and their traps are like that, or they're trying to look up, is sometimes you need to bail, either reassess or like kind of get back in, like restart yourself. And if that's the case and it's just not for them, go in and mobilize it. Just teach yourself techniques. But so those are some really good techniques all around. There's a lot more for each area. I'd say there's probably at least 4 or 5 more per area. Yeah. So it's really good to diversify. You think, you have your bread and butter techniques, not gonna lie. So that CT junction one that we just demonstrated is my bread and butter technique. If there's no patient preference or anything like that, I'm going to do that one because it's quick and I'm just more effective at it than the other techniques. But knowing some other ones, someone, they have their shoulder is part of their problem, so they don't want to get up there, or they're too broad chested. I'm working on Big Al there with his, python arms and stuff. There's no way I can wrap around and kind of loosen my hands through. So knowing the prone technique or another seated technique, or you may get in and it's like, oh, that's uncomfortable to put myself like that. All right. It's not so much the area, it's definitely the area that you're wanting to target is the problem, but maybe that position's not great. So knowing 3 or 4 techniques and having them in your tool bag is really critical. And then once you get more and more skills versus just like preference, you can start like, oh, this technique is more for issues with extension or rotation and those sort of things. But, at least know enough techniques for your clients to make them as comfortable as possible. But that was a little long-winded. I think we covered everything. Brandon, you got anything else left to say, or should we wrap it up?
Just to add on what you're saying, there's no correct technique in terms, of you have to do one over the other. It's really which one is more comfortable for you and most comfortable for the patient, and which one you perform the best. Depending on your skill set, your experience level, and like Jeremy was saying, the body size or stature of the person you're working on, it may lend you to do one technique over the other. It doesn't mean it's more effective or less effective than any other technique. So I know some schools teach it as, one technique's more effective than the other. That's not true. Hence why Jeremy and I created this library here of over 100 variations and techniques so you guys can have access to a bunch of different variations and have, step-by-step instruction to do it as well. So that's on my website, pursueptnow.com. Click on the virtual learning section and it'll be there. Other than that, that's pretty much it. I guess announcement, we are end of July. We have a 1-day fun extremity manipulation course, both upper and lower extremity, coming up in mid-September. We'll be providing PPE, masks and things, trying to space people out as best we can. But that course is coming up in 6 weeks, so hope to see some people there. Any questions, please reach out to us. And Jeremy, I won't take that thunder from you. You usually do that, so
It's the only thing I do good at.
you do it well, so I'll
My
hand it off to you.
shining moment in life is the conclusion of this podcast. But yeah, anyone goes to that course, I'll give you a free Nips and Sips t-shirt. Super rare, legendary shirts.
Limited edition.
Feel like butter on your body. But if you have any questions, comments, concerns, want chat a little more, a little clinical dialogue, you can reach us at Nips and Sips on Instagram and Facebook. We're also, me personally, I'm at The Decent Doctor and Trifecta Therapeutics. Brandon's at Think Like a Fellow and at Pursue PT Now. Thanks for listening in, guys. Great episode, and I'm out, but cheers, everyone.
Cheers.